Welcome to our discussion on pediatric renal transplant and patient education. My name is Dr. Regidor III. Let's explore the intricacies of this vital topic. Thank you for your time. We will discuss patient education post-renal transplant, focusing on children. We'll also discuss kidney transplants in pediatric patients and the unique considerations for kidney and pancreas transplants in diabetic children. We'll explore the surgical replacement of a child's failed kidney with a donor kidney, emphasizing lifelong medication adherence, infection prevention, and regular follow-up. This includes diabetic pediatric patients, as conditions like type 1 diabetes can lead to end-stage kidney disease. The kidneys are located in the posterior abdomen, causing flank pain when irritated. Costovertebral angle tenderness indicates kidney issues like pyelonephritis. A flank incision is used for nephrectomy, while transplantation involves a lower abdominal approach to connect the donor kidney to pelvic vessels in the bladder. Post-transplant education is crucial for pediatric patients. Legal guardians must be involved, as patients aged 14 to 17 are still considered children. Guardians are responsible for understanding and consenting to health education to ensure proper care and adherence to medical guidelines. Guardians must ensure immunosuppressants are taken exactly as prescribed, lifelong, with no missed doses. Common drugs include tacrolimus, cyclosporine, and steroids. Do not adjust doses without medical advice. Be aware of side effects like tremors and weight gain. Avoid over-the-counter drugs unless prescribed, and consult a doctor before using herbal supplements. Due to immunosuppression, infection risk is high. Practice strict hand hygiene, avoid crowded places and sick contacts, especially early post-operation. Wear a mask when necessary and report any fever or signs of infection immediately. Recognize signs of rejection urgently: fever, reduced urine output, swelling in face or legs, sudden weight gain, and pain or tenderness over the transplant site. Immediate medical attention is crucial. Attend regular clinic visits, especially early on. Routine blood tests, including creatinine and drug levels, are essential. Monitor blood pressure, weight, and urine output at home to ensure optimal health. Adopt a low-salt, balanced diet and ensure adequate hydration. Avoid raw or undercooked foods to minimize infection risk. Gradually resume normal activities, but refrain from heavy lifting initially. Ensure vaccinations are current, but avoid live vaccines unless approved by the transplant team. This is crucial for maintaining health and preventing infections post-transplant. Monitor your child's temperature and contact the transplant team if it exceeds 100.4 degrees Celsius. Weigh your child daily. Sudden weight gain may indicate issues. Observe urine output for any decrease. Regularly check blood pressure, as high levels can signal kidney problems. This discussion is on kidney transplants in children aged 2 to 10 years. We'll explore the unique aspects of the surgical procedure for this age group. For children aged 2 to 10, legal and surgical requirements include obtaining valid informed consent from a legal guardian and child assent when appropriate. The procedure must prioritize the child's best interest. A comprehensive preoperative assessment is essential. In emergencies, life-saving treatment can proceed without consent if delay risks death, adhering to child protection laws and hospital policies. Preoperative surgical clearances are crucial. Ensure immunizations are up to date, as live vaccines are unsafe post-transplant. Conduct human immunodeficiency virus and hepatitis tests. Evaluate bladder function, especially if kidney failure is due to birth defects. A pediatric nutritionist must assess growth and nutrition, focusing on weight and bone health for optimal recovery. For a 2-year-old child weighing 10 to 15 kilograms undergoing a kidney transplant, precise preoperative preparation is crucial. Due to their small bodies, fluid and blood sugar management is critical. Clear liquids are allowed up to 2 hours before surgery, breast milk up to 4 hours, formula or light snacks up to 6 hours, and full meals up to 8 hours prior. In pediatric kidney transplants, The new kidney is placed in the lower abdomen, typically on the right side. The child is positioned with a slight lateral tilt during surgery. Critical connections include the renal artery to the external iliac artery, the renal vein to the external iliac vein, and the ureter to the bladder. Flank pain is common in kidney conditions due to the kidney's location and nerve stimulation. Costovertebral angle tenderness helps assess kidney inflammation, particularly in infections like pyelonephritis. Flank incisions are used for nephrectomy because the native kidney is retroperitoneal, unlike transplanted kidneys placed in the iliac fossa. In kidney transplants, the new kidney is placed in the iliac fossa, typically on the right side. The extraperitoneal approach allows surgeons to operate in the lower abdomen without opening the entire cavity. This anatomical positioning clarifies the use of flank incisions for nephrectomy, not transplants. Nurses should obtain legal guardian's consent before explaining procedures to children under 17. The kidneys are located on either side of the spine in the retroperitoneal space, with the right kidney slightly lower due to the liver. They are protected by the lower ribs and back muscles, including the psoas major and quadratus lumborum. Nurses should be aware of key immunosuppressants used for anti-rejection therapy. These include tacrolimus, mycophenolate, mofetil or sodium, prednisone or prednisolone, cyclosporine, azathioprine, sirolimus, everolimus, and belatacept. Understanding these medications is crucial for effective patient care and management. Nurses should note the importance of prophylactic and supportive medications. These include trimethoprim sulfamethoxazole for antibiotic prophylaxis, valganciclovir or aciclovir for antiviral prophylaxis, and nystatin or fluconazole for antifungal prophylaxis. Additionally, proton pump inhibitors provide gastrointestinal protection, while vitamin supplements and pain management medications offer nutritional support and pain relief. Type 1 diabetes mellitus with end-stage renal disease results from autoimmune destruction of insulin-producing cells, causing chronic hyperglycemia. This condition progressively damages the kidneys, necessitating a combined kidney and pancreas transplantation to restore renal function and insulin production. In severe type 1 diabetes mellitus with end-stage renal disease, a simultaneous pancreas kidney transplant can restore insulin production and normalize blood glucose levels. This eliminates dialysis, improves survival and quality of life, but requires lifelong immunosuppressive therapy and careful monitoring for rejection and complications. Robotic transplantation surgery enhances precision in simultaneous pancreas kidney transplants. It translates the surgeon's hand movements into precise tremor-free actions, improving surgical outcomes. For simultaneous pancreas kidney transplants in children weighing 10-15 kilograms, intravenous fluid management is crucial due to nothing by mouth status. Maintenance fluids, such as dextrose solutions like 5% dextrose in water or 5% dextrose in half-normal saline, are administered to stabilize blood sugar, particularly important for those with type 1 diabetes. For simultaneous pancreas kidney transplants in children, pre-sedation may involve a mild sedative to keep young patients calm. Vitamin K is administered if blood clotting is a concern. Induction immunosuppression, such as thymoglobulin or basiliximab, is crucial to prevent organ rejection. Intravenous antibiotics are given within 60 minutes of incision to prevent infections. In children weighing at least 10 to 15 kilograms, glucose monitoring is crucial every 1 to 2 hours due to nothing by mouth status and diabetes. Potassium levels are checked, and if high, dialysis or intravenous insulin glucose may be needed. Managing an insulin pump is critical. Insulin delivery is halted once the donor pancreas functions to prevent hypoglycemia. In open surgery, a vertical midline abdominal incision is used. Robotic-assisted surgery employs a steep Trendelenburg position for better visualization. In simultaneous pancreas kidney transplants, the patient remains supine, with the pancreas placed in the right iliac fossa and the kidney in the left, using the same midline incision. During a pancreatic intraoperative transplant without the kidneys, the patient is positioned supine, with arms either tucked or extended. Bony prominences are padded to prevent pressure ulcers. A warming blanket maintains body temperature, and compression devices prevent deep vein thrombosis. A continuous intravenous insulin infusion with dextrose is administered to manage blood sugar levels throughout the procedure. The C-peptide test is the gold standard for confirming insulin production. When the pancreas produces insulin, it also generates C-peptide. Synthetic insulin lacks C-peptide, so high or normal levels in a blood test confirm that the insulin is produced by the transplanted pancreas. Serum amylase and lipase levels are crucial markers of pancreatic health. These digestive enzymes help indicate if the pancreas is inflamed post-surgery. A steady or decreasing trend in these levels suggests the organ is healthy and likely producing insulin effectively. In children, signs of delayed graft function for kidneys include low urine output despite adequate intravenous fluids, rising creatinine levels indicating waste accumulation, and the potential need for dialysis if the kidney doesn't recover within the first week. Delayed graft function in children post-pancreas transplant can manifest as high blood sugar, necessitating insulin intervention. Low C-peptide levels indicate insufficient natural insulin production. Elevated amylase or lipase suggests pancreatitis. Tenderness or firmness in the lower right abdomen may also occur, indicating inflammation at the transplant site. Overall nursing care for simultaneous pancreas-kidney transplant is to monitor vital signs, blood glucose, and urine output to assess graft function, administer insulin and immunosuppressive therapy as needed, watch for rejection signs like fever or hyperglycemia, use strict aseptic techniques to prevent infections, manage fluid and electrolyte balance, and provide nutritional support tailored for glucose and renal function. Monitor blood work closely, especially in the first 24 hours. Surgical stress and high-dose steroids, such as methylprednisolone, can elevate blood sugar levels. These factors require vigilant observation to manage potential hyperglycemia effectively. For simultaneous pancreas-kidney transplant, it is important to assess the surgical site for bleeding, infection, or leakage. Educate the child and caregivers on medication adherence, glucose monitoring, and follow-up. Provide psychological support for the child and family, and encourage gradual mobilization and recovery activities. For further reading, consider these key references on kidney transplantation and delayed graft function. They provide valuable insights into outcomes and risk assessments in both pediatric and adult populations.